Sorry, my house phone rang as well.
Hi everyone. Yes, so I think I'm live now. So let me just. Okay. Hello everyone, welcome. We're having a few slide hiccups, so I'm just going to take us I'll do a few housekeeping and brief introductions while we wait for the slides to show up. So firstly, let me welcome you all, and it's great to have everybody join us in the strange new world that we're now doing things, and I hope you're all sort of adjusted and accommodated to Microsoft and these sort of webinar formats. So if I just take us through what we're going to talk about. So as you're probably well aware, this session is about how to implement the electronic safety netting toolkit that we've developed within EMIS Web. You're probably all aware that when you join, you're muted, and we advise that you stay muted. We're going to have lots of opportunity for chat and addressing FAQs and questions that come through the session. And so please do find within Microsoft, if you go to the Q&A section, that's where it'd be great if you can put your comments. We've got two facilitators helping us run this webinar, and so we can hopefully get your questions published and addressed. We'll aim to go through the slides and present to you the toolkit, how to utilise it and how to utilise it in this COVID period, and then have a good ample time for running through all the FAQs. So let me just check so my two colleagues who are helping run the session are Catherine and Vanessa. And have we made progress with the slides at all?
Not just yet, Afsana, just give me a moment.
Okay, then while we're waiting, I'm presenting the session today, and it gives me great pleasure to present Rasha and Philippa. So why don't you unmute yourselves and talk about who you are and what you do, and then we can hopefully have the slide decks up and running by then. So Rasha, why don't you go first? Unmute yourself.
Thank you, Afsana. Hi, everybody. I'm Rasha. Some of you may know me from various places around general practice. I am a portfolio GP. I'm a successional salary GP in a practice in Barnet. I'm the QI lead for the practice there and have been doing that for about 4 to 5 years. And I also am one of the co-founding team members of a digital health platform called My Health Specialist, which also is a patient safety initiative aimed to help protect patients who choose to go into the private sector by helping them identify the most doctor recommended specialists. I was delighted to be asked to be present on this webinar. As a QI lead, I'm quite passionate about patient safety initiatives, and when I come to talk to you a bit more about the slides that I will take over from Afsana, I'll explain to you a little bit about my motivations behind trying to implement this toolkit, which we onboarded last year to our practice very successfully, and how it's been really quite game-changing for us. And also how I think it would be really quite an important toolkit to talk about given the current COVID climate. I'm not a cancer specialist GP, but I'm definitely a QI-led GP, and this absolutely is for everybody to consider. So if I hand over to Philippa to introduce herself, and then we can talk more about our stories and our journey when we get to that junction in the slides. Thanks. Philippa?
And it's Philippa.
Can you hear me? Rasha, can you give me a thumbs up if you can hear me? Okay, good. Okay, so I'm a Tower Hamlets GP. Some of you may know me because I also have a lead role in NHS England and NHS for appraisal. And I went to training on this safety netting toolkit with Afsana a couple of years ago, and I was really impressed with it. so implemented it in my practice, but also felt it had a really wide-ranging use for everybody. I've seen lots of near misses and things that haven't gone quite right, and this seems to be a very useful tool for all practices to implement. So I was very keen to get involved in running out the training, and so I got involved with that. And then we've got 3 generations of trainers here. So Rasha came to one of my training sessions and is now involved with training. So it's a really good job. It can work well.
Great. Thank you. I'm just going to start on the introductions, give me a bit of the narrative for those who are not aware of the safety netting until we get these slides sorted. Can you all hear me? Yeah, okay, grand. So I forgot to introduce myself. So I'm Afsana and I'm the Alliance GP lead.
Right now, I think this is your screen that you're sharing, is it?
Vanessa, I think we can all hear you. So I'm just going to, so I'll just carry on. So I'm the Alliance GP lead for the North Central Cancer Alliance, and safety netting has certainly been the sort of my pet project in my work in the Alliance, and really the drivers for that started back in 2015 when we had NG12 and then the Independent Cancer Task Force report released. So in the early stages we developed this a guide to improve quality and safety netting, and that was then mobilised and developed into a module on a learn zone with lots of support from Macmillan to allow that to happen, and that went on to be accredited by the Royal College of GPs. And then that was really the precursor for the safety netting toolkit that you are going to learn about in this session today. And it was really just to highlight that this work has really been a big example of kind of innovating and testing, demonstrating and revising the toolkit through lots of piloting work and feedback from GPs, learning lots about the challenges that occur with quality improvement, so the spread of the challenge and scaling up, and then finally getting the toolkit nationally available on EMIS Web back in June 2018. And since then, as an alliance, we've been really working to mobilise and implement the toolkit into practices in our geography, but actually it's because it's a national toolkit, it is has been widely implemented in many sectors in London and outside London. So that's where we were, and then obviously as everybody knows, we then hit the age of COVID, and then that really sort of propelled the need for us to do something more to support implementation, partly because of the pathway changes and the real need to robustly safety net within primary care. So we did develop a specific SOP in response to that, and we will sort of cover that hopefully a bit later on. We still haven't got anywhere with the slides, and I can only apologise for that, so I will just carry on and you just look at my face. Just to let people know that, you know, we have had quite a wide outreach in terms of the video usage. The user video has had almost 3,000 views. So that's, you know, that's good news for us, and obviously we want to reach more people, more practices and support practices. Just to cover a bit more about the COVID-19 impact, what we have discovered in this journey is that actually the way patients have been seeking health-seeking behaviours have changed, and the referrals into the cancer pathways have been impacted dramatically. Oh, whoopee, we've got some slides. Thank you so much. Okay, so, and you can see, yeah, if we move forward, we want to get to slide 7 now, please. And that was just a screen grab to show you how many people. And the next one, please. Yeah, so what we really discovered was that actually people were not accessing the healthcare services across many specialities, from A&E to paediatrics and obviously to cancer. And at one point we'd seen a 70% reduction in the suspected cancer referrals. And that really, you know, that was a real huge concern, and is an ongoing concern for us in the cancer community. And so in response to that, you've seen sort of national campaigns for the NHS Open for Business and Business as Usual. And this is really where, you know, we think that this toolkit really plays to its values, in the sense that there's so much more that we can do to support encouraging referrals and ensuring people go for referrals. So I have done enough talking, so I'm going to hand over to Rasha, who's going to kindly take you through the toolkit itself and how to implement and utilise that. Thank you, Rasha.
Thanks, Afsana. So I did touch earlier on about my role as a QI lead, and these are really difficult times. We talked about this in the coronavirus era, but even historically, I think the risk has always been with our cancer patients is that we all have our own independent safety nets, and we had our own processes in place. I think as a QI lead for a practice or somebody who's trying to improve patient safety at large, there are always three questions I ask myself when looking at new innovations like this. The first one is it going to enhance patient safety and improve the patient experience? The second is, does it reduce the workload to the clinicians? And the third is it easy to implement and roll out? And if the answer to those three things is generally yes, which this toolkit is, then for me that's very indicative of something that we should be piloting. And so back in June 2018, I got trained by Philippa and Afsana as well. And I really loved this toolkit. And I liked it for lots of reasons. I don't know if any of you have read the book, The Organized Mind. It's a really good book by Daniel Levitt, and it talks about kind of how to organize yourself in a digital age of overload. So it helps to decant things that are important into other places, and therefore freeing up your mind, so you're not holding so many patients in one go and so many things. So this is an EMIS Web tool. So for me that was a really important thing, because that's how we work. It has 4 main pages to it, and it allows you to monitor the referrals you make for cancer. So every time you do a 2-week wait referral, you can log it with a diary entry. It also allows you to monitor patients who you refer for direct access tests. So for example, if a patient has a PSA that you send off and you want to remind yourself or safety net that patient, you would set the tracker to do that. And we'll talk a bit more about how that is done going forward. The good thing about it is it codes the event. So once you've templated it, it will come up as a little pop-up, like a quaff box. So anytime a clinician sees that patient subsequent to you, they know that they are on the tracker. So it might help to alert second clinicians. I think the good thing about this tool is we took it on full throttle. I really put a bit of resourcing behind it. We made sure that we had the right administrative support. It wasn't hard to implement, but it required the whole team to be on board together. Sorry, let me just get rid of this box. It worked brilliantly for us, and we've been doing it for 12 months now, and we've audited the outcomes, and it has genuinely saved a couple of patients from falling through what would have been a slightly disjointed pathway. Sorry, I'm just trying to move the slides along. Okay, so I thought it would be helpful, because when I went on my training, it was really helpful to get an overview of actually what is required in implementing this toolkit. And the first thing is, and we'll talk about this as well, is how you would locate the toolkit on your EMIS library. So we'll talk about that in a second. It's about finding it on your desktop and activating the toolkit, and that just launches it. The second thing I think that's really important is to get on board with your team. So I think it's important that you have a meeting, or you talk to your clinical team and your administrative team, that this is a new level of safety netting patients. And for cancer, yes, but also any high risk patients. For me, it's not so much of a net, it's more of a very tight pipe, and it just moves that patient every kind of junction along until you get the patient from, a suspicious symptom, which is the first part, all the way to the end of their journey, whether there is clinician and patient reassurance and or a diagnosis. So really bringing that into your team is quite important. I think there's some useful videos and resources we'll talk about later for doing that. The third thing is how you would use the template in a 10-minute consultation. And actually, it's super quick. It's a matter of clicks and it's pretty much done. And of all the things that we've had to do in pivoting in our digital COVID era, this is very straightforward. We're all getting much more used to using these things, but this is really a few clicks. It requires, however, when you do implement, when you do put the template on, that you give quite clear instructions to your team as to what you would like them to do with that information. And this will be demonstrated a bit later on. And there is a tracking function. So we resourced our team, so we created a process where one of our senior operational managers or a senior receptionist took a bit of ownership of this, and it's timetabled every week on a Monday that they will run the search and they will activate the actions on there. So every single week that search is being looked at and the relevant patients are being contacted and the appropriate feedback is being given to the clinician. And then it's how you communicate the toolkit to the wider team, and that can be via tasks or spreadsheets. So just to talk about first step about locating and activating the toolkit. All this information will become available to you, and it's very straightforward. If you go onto your templates and protocols tab in EMIS and then you launch your EMIS library, you will find in it a folder that says third sector partnerships. And in that folder, there is a Macmillan Cancer Support tab, and then that launches the Cancer Safety Net. So if you right click on it and activate it, that activates that toolkit template on your desktop. I just want to talk for a minute about the types of patients that this is appropriate for. From a practical step, we layered this on. Okay, so we started very much using it just to log all the 2-week wait referral forms that went out, and we did that for a period of a month or two, just to make sure the system was safe and it was robust and that everybody was comfortable using it. But because we have been using it for a year now, and given the current COVID situation where we all feel we're holding very high risk symptoms and patients, we found it really easy to use the toolkit to monitor all sorts of high risk groups. So what's happened here is we've kind of collated the patients into groups to show you specifically in the cancer COVID era what types of patients could be applied to this toolkit, and this will become relevant later on when we show you some of the pathways for that. So group 1 are the patients who traditionally meet the 2-week wait pathway criteria. So they are patients who have had who meet these suspected cancer guidance, and either the new ones that have cut. So we've all got two kind of templates sitting side by side. Some are COVID superseded by the older ones, and at the moment in our practice, certainly some of the specialist areas are flitting between the two. But group 1 are for all patients who fit the COVID cancer pathway or the traditional NG12 compliant pathways. Group 2 are the patients who fit the new COVID cancer pathways, but the new cancer COVID pathway is not met by their current symptoms, but traditionally they probably would have been able to be referred on a traditional 2-week wait pathway. So as we know, they've become a bit more selective in this current time. So group 2 are for those patients. Group 3 are for patients who are at lower risk, who probably don't qualify for a 2-week wait, but we have referred them for direct access investigations. So these are blood tests, x-rays, ultrasounds, CA125s, PSAs. So that's group 3. They don't quite fit the 2-week wait, but they're high risk enough for you to want to monitor. And group 4 are patients living with cancer who may need ongoing monitoring. And then group 5 are patients with cancer who are very high risk during this current time, and you just want to watch them. So we've kind of utilised the tool for all of those. And just really quickly, I just wanted to show you in a very brief stepwise way what would happen if you were in your consultation. If you look at the top of your consultation tab, you will see the run template, which we're all used to using for various things. If you click on it, you'll get the screen next to it, which, as you can see, the most used template I have is the safety netting one. So that sits quite firmly at the top of my picking list. And then when you click on it, you'll get this following screen. And we'll talk about what you do here, but essentially this lists all the 2-week wait pathways, so the referral forms, and you would click that and set a date 2 weeks ahead and save it. So that's the most functional basic use of the tool at this stage, but we will go into it a bit further. I'm just going to hand over to Philippa. Philippa, like I said, trained me, so I'd like her to perhaps train you the way she trained me, because it clearly worked, about how to actually physically use each of these pages. Philippa.
Thank you very much, Rasha. And I'm going to go through some of the kind of actual nuts and bolts of the actual template as you'll use it. As Rasha's already said, it's got 4 parts to it, really. Probably the first part is the most familiar, that people will probably already have some system in place in their practices for tracking 2-week waits. And sometimes you might want to do an overlap with your current system and the new system until you've got this fully embedded. But this first page, so if you look down the left-hand side of the screen, you'll see there's 4 tabs. So we're looking at the top tab at the moment, which is urgent suspected cancer referral. So these are all your 2-week waits. And then you can log whichever 2-week wait you are doing, and then set a diary entry. So there's a diary entry box. So in normal times, we'd have advised to set this for 2 weeks. And then what happens is that it's all coded entries, and a diary entry goes in. And after the 2 weeks has elapsed, the search function will allow alerts to be raised that it's gone beyond the date that you'd want to know that something has happened. So that's the first page. I think I'd like to just re-emphasize a couple of things that Rasha said, that this is very much a team effort, that it's not going to work if you've got like 1 or 2 keen clinicians who want to use it and the rest of the team is not on board. This only really works if you get complete team buy-in and have kind of education and training meetings across the whole team, and that you've got the admin support to back it up. So some practices have said in the past, oh, it's going to be more work, it's actually going to create more work. It creates different work, and it is a more systematic approach that hopefully will not let things slip through the net. So it creates a different type of work, but hopefully you'll all be convinced in the long term it actually reduces risk, it's better for patient safety, it stops lots of individual messages going across practices, and has it all contained in one neat area. So yes, so the second page down, so on the left hand side now with the second tab down, and this is to do with direct access diagnostics, which at the moment is probably not what we'd normally have, but it's a place for when we are referring for any investigations you can record on here. So it's got all of the things like X-ray, ultrasound, CT, MRI, gastroscopy, colonoscopy. It's got a tab for blood tests if you want to know for sure somebody's actually had their blood tests and you've got the results back. It's got a urine one, and then at the bottom, actually, this is probably quite relevant at the moment. It's got a ability to track fit testing. So one of the changes to the pathways, certainly for us locally, is that there's an increased use of fit testing prior to referring, where we might have done 2-week wait for bowel, lower GI. We're now being asked to do fit tests. And this is a place where you can record that you've requested a fit test and that you want to look and make sure the result has come back. So that's the second page down. And the third page down, so again, Rasha mentioned that different practices might want to implement this at different rates. So I think most practices have said, okay, we're going to definitely implement the first page, the suspected cancer referrals. And then some places have said, okay, yeah, we can get, we've got that sorted, we'll go on to do the direct access diagnostics, and then maybe introduce some of these other ones at a later date. And some practices have just gone, I'm going to go for the whole thing all at once, but that's up to you as individual. So this is the third page down. This is the safety netting symptoms area. So this is where you might think this is, I'm not so worried that it's a definite 2-week wait referral, but I'm a bit worried, I'm a bit concerned, and I don't want this person to get lost in the system. I'd like to follow things up. I'd like to make sure that that they are actively monitored, that we review them in a few weeks or a month or whatever you feel is the appropriate thing. So it's got active monitoring of patient, and then it's got another diary entry that you can set. And then there's a text box. And I think one of the important things here is that you put in as much text as possible. If you're imagining it, reading it as if you were a different doctor, that you'd understand what the concern was and what you were hoping was going to happen, so that if for whatever reason you as the clinician aren't in the practice, which is actually quite relevant at the moment with COVID, that you might not be there, and that another doctor was seeing this alert when it had gone past its due date, that they'd understand what the nub of the problem was. And it's good for practices that have lots of part-time workers. It's good for places that have got locums, that if something's been entered here, it doesn't get lost in the system when a patient sees a series of different doctors. So that's the safety netting one. And then you can put in, so it's given an example here. So it's given bloated, if it continues for another 2 weeks, to get a full blood count and a CA125 and then see GP. So you can see there, if you put more text in, it's obvious what the concern is. And then you've got a tab to put in a diary date. So this is suggesting we follow this up in 2 weeks' time, but you can put whatever time interval you want there. So that's the safety netting for symptoms. And then the final page, page 4, which actually we've got the wrong one highlighted down the left-hand side, but page 4 of this template is for monitoring people that have cancer or have pre-cancer. So for things like colonoscopy that needs to be done in a year's time, when you get that letter back saying repeat in 1 year, you can put that on here. And then the beauty of this system is that the alert won't come up until 2 weeks before it's due. So it'll come up as a pop-up visible on your EMIS, but it won't do it all the time. And it'll be kind of in a way it's a distractor. It will come up at a relevant time, which is 2 weeks before it's due. So if anybody happens to see them, it will be there. But it will also then come up when it's overdue on the searches that are run. So things like colonoscopy, the really good one is like Barrett's esophagus that needs a repeat endoscopy. And when we first ran this first search, we picked up somebody that had been coded as needing a follow-up in a previous surgery, and it came up on the first time we ran a search. We were able to contact that patient and say you're overdue an endoscopy for Barrett's. It can track things like PSA. If you need an annual PSA, you can put that in here and get a diary entry come up for a year's time. And another one people use it for is DEXA scanning. Yeah, so I think that was all I was going to say, and I'll hand back to Afsana, I think.
Thank you. I'm just unmuting myself. Can you hear me? Yeah. Okay, grand. So the next two slides really take us through the initial chart that Rasha had gone through with defining kind of these 5 groups. So as we know, COVID has really accelerated the need for robust safety netting, and in the Alliance, once COVID had really hit, we really spent some time to define some specific COVID-related scenarios that Rasha's gone through in the details of there, and the flow chart is taken from the SOP, which was already sent out to primary care through the STP bulletin, but these flowcharts quite succinctly summarise those pathways. And just to highlight, obviously there's the group 1, which is your suspected cancer referrals that you should be robustly safety netting, and also to highlight the pressing need for that even more when we know that patients are not attending their GPs, even when they're referred, they're not attending for their referrals. So this is a really important pathway. And then group 2, which we've alluded to, and the big highlighted one here is really the lower GI pathway, where before a lot of areas within London had seen fit for low risk. It's now fit for low and high risk as your entrance into that pathway. So really the robust safety netting of that fit test, getting it back and making sure that the appropriate action is taken depending on where the fit result falls. So I don't think I need to sort of labour the points again on group 3, and Vanessa, if you move to the next slide, then to the next slide. Oh, sorry, I was confused. So go back up one. Yeah, so this is group 4 and 5, so which we've highlighted already. And then I'm going to pass back to Rasha, who will take us through the searches and the latter end of the safety netting closure.
Thanks, Afsana. I think you've seen, hopefully you've seen how the process has been from a clinician point of view. So once you've activated the toolkit, you've charted the entry and you saved it, then what happens at the other side, and certainly what we did in our practice, is we nominated a lead administrator. And I think that's quite important because a big part of what happens to these patients hinges very carefully on how your administrative process is run. So there is a process by which every single week the administrative staff can pull out the search. So they will pull it out and it will present itself a bit like this chart. So they will get a grid or a spreadsheet essentially, which gives them the patient EMIS number and details, patient's date of birth, what they were coded for, and any text that you have written. And just echoing what Philippa says, the more explicit you are in your text and instruction, the more value you're going to get from this toolkit and the less back and forth you're going to get between the doctors and the reception staff. So every single week, one of our team pulls out the search and they contact each one of the patients to make sure that they have had the appointment, they've attended the appointment, that there's been some sort of outcome, and that is then fed back to the GP who did the referral and the alert and template in the first place. And based on what you've put in the text is pretty much the instruction your administrators or a fellow colleague will follow. So this is about closing the loop of safety. Once I've fed back to my team, so what happens in our practice is our senior administrator runs the search. She'll send me a task to say, you did a fit test on this patient, it's come back positive, check the results and take the next appropriate step. I will then feed back to her and say, I've seen this patient, I've done the appropriate or the needful, you can close the tracker. And she will then confirm the event has been completed. She'll go to the diary entry in the patient records and she will complete that task. So that will then disappear from that patient's record and we know that the full loop has happened. The benefit of this is obviously, I don't know if you all feel the same, but I've noticed a pushback, even pre-COVID, from secondary care in terms of in the olden days, I'll say, but when I first started doing primary care, patients would have, say, an anemia. We'd forward them for an upper GI. If they didn't find anything, they automatically got a colonoscopy and various tests and came back with a diagnosis. That doesn't seem to be happening as much anymore. So what will happen in the situation, for example, is that patient would come back, we would complete the loop, and then it may be that you as a clinician want to trigger off another referral or another action, and then you would do the cycle again. Administrative staff in our practice, and we would encourage it, are asked to add a comment to that tracker once they have completed it, and that means that there's a full audit trail of what happened to that patient, and then the event doesn't pop up anymore in your quaff box. So that's the main thing, is that the communication between you and the admin is quite straightforward. So just something to just gently alert any of you to. So it may not be applicable for any of you now implementing it new, but certainly for some of us who are using it traditionally, it's quite important that you check that the SNOMED and read coding searches are harmonized. When we launched this SNOMED, we had one folder in which to run the searches from, and then when the SNOMED coding came on, it sort of sat side by side to that. So I think it's just quite important that you are aware that when you implement this, just to be sure that both read and SNOMED searches are checked so that you capture all the tracked events. So there's quite a few ways to do this, to apply this toolkit. We started off as a small practice level, so we did it as a proper QI initiative. We did it for 6 months. We audited it. It was robust and it was worked really well for us. And then we started to share it. And it can be done at a practice level, which is what I would suggest you all trial to do first. But I think there are really seriously there are some good applications for this sort of at a PCN level, and looking at scaling the searches to a back-end office function or identifying a tracker lead for a PCN rather than just the practice. So I think there comes a point where actually you can scale this operation. I think going slightly beyond the PCN level, if you're going at federation levels, there's obviously the question about, is this too overwhelming at that stage? But I think certainly I would really encourage you all to start trying to use this in your actual practices. It has saved quite a few SUIs on our side. And so I'll hand over to Afsana to do the last few slides for you. Afsana, would you like to take over the microphone just to do the last bit? I can't quite hear you. We're just trying to get Afsana to make some sound.
Here we go. Sorry, someone muted me. I was muted. So now, can you hear me now? Yeah? Good. OK, so can we just go back what the previous slide for me, please, just to quickly. Thank you. So the reason we put this here is that so we've had lots of conversations with primary care at different levels, so practice level to federation level, and there's a real ask about how this could be done more efficiently. And so this is really why we put this on here, particularly if there is anyone on the session today who are sort of representing a PCN or even a federation, because we've already been having kind of conversations about how this could work in different ways, and these are our early thoughts, but we're always open to more discussion about how this could work in terms of really making it efficient for the back office staff to do much of the tracking. And secondly, my point really on here is that, as Philippa has already alluded to in quite detail, this is a real practice initiative, so back office and clinicians working together, and there is a perception that this can increase workload, and actually what we've found is it just centralises the workload, and so we did quite a extensive piece of service evaluation last year, which we've evaluated, and certainly the themes that come out from that is that clinicians definitely do see a downturn in their kind of admin burden, while obviously the administrative team are now carrying that. So it's kind of been displaced, really, is the way to kind of highlight that. OK, next slide, please. And so that takes us sort of near the end of what we wanted to go through with you. And it was really just, this slide was really just to sort of highlight the reflections which kind of mirror and align with many other kind of quality improvement journeys that people have had, where we really couldn't have got to where we got to with this stage without those early adopters and innovators, champions, so people like Rasha and Philippa, and really kind of believing in the innovation and taking it forward, and obviously the practices themselves taking their time to implement this on the ground. And the other really important aspect for this tool is that it is for primary care. It's been a real win-win because it enables robust tracking far beyond the cancer picture, and so hence patient safety is the heart of this tool. And should we move the slide? So we put a couple of FAQs down because these have certainly been things that cropped up many times in the previous sessions that we've held across North Central and North East London. And I know that there have been few questions that have come up across here. So I thought we could, I'll just check the Q&As. So should we, if we go through some of the questions and look at the FAQs, and then perhaps I can direct them to Philippa and Rasha as needed. So there was one on the question about locating the template, and I've actually just addressed that in terms of sending the question with the link to the screenshots on that. So I hope that addresses that question. There's one here that says, is it possible to set more than one diary reminder for a 2-week wait? So for example, one in 2 weeks and another after 1 or 2 months, so that we can double check that it's occurred. So like many of these innovations, we're limited by what EMIS Web is able to do, and so you can't set 2 diary entries for the same read code. Obviously, within the template, if you're read coding different events, it enables you to do that, but for the same thing, it can't. So if you put another one 2 months ahead, it will replace the existing one. So unfortunately, that is not possible. Can I hand to, so Philippa, do you want to take, are there any sort of thoughts or questions that you have? Because there's not much else come through from what I can see. Were there anything else in terms of prominent questions that come up for you during the sessions?
Not a question, but I wanted to just give a plug for your YouTube video, which I think you put in one of the early slides. I think it's really useful if people go away from this and are trying to explain to other people in their practice. It's a 7-minute video, and it goes through the template step by step, and exactly what I went through. It goes through, and yeah, so I'd really recommend that if you're thinking about implementing.
Grand. Okay. So we've got another question. So can this toolkit be used to support the PCN DES specification? And do you know if this on a PCN level would be appropriate? Thank you for that question, Bobby. And that's absolutely something that we've been certainly prior to COVID wanting to in fact deliver for North Central London, the geography that we cover. So yes, we believe so. We've been working with the federations to understand how that can be practical, and that hence why there was that slide on the models for applying this. So the DES, as you know, is probably going to be reactivated in October, the PCN DES for early diagnosis, and so within that it sort of talks about safety netting as well as screening. So yes, completely appropriate. And we've also got a question from Pawan. Hello, Pawan. And any experience of ANPs, PAs, paramedics using this tool? So that's a really good question. So I mean, I can just, oh, sorry, was someone trying to say something? Nope, okay. So I can sort of talk about my experience with that, and I don't know if Philippa and Rasha want to offer anything alternative to it, but basically the experience that we've had in Islington and from what I've heard from NCL is that with the driver for the ANPs, PAs and paramedics came in with the new GP contract of 2019, and that was really the advent of enabling a wider primary care workforce, and so in that we've sort of really seen, for us personally, we've really seen pharmacists plugged into it, and so we've been trying to see how that would work. And at that time, so this is pre-COVID, it wasn't something that we'd necessarily focused on, but I do think that this is an opportunity, and we've not really had any experience with seeing an opportunity for sort of ANPs or PAs in this area yet. I don't know if Philippa, Rasha, you want to add anything to that?
I really can't see why, you know, any member of the team and with the increasing skill mix that we're all working with, you know, as long as people are part of the team, then why not?
I would probably echo that. I would say that you know, the toolkit applies itself to any clinical context, that perhaps they may not be the ones doing the 2-week wait referrals and using the first tab, but they may well be monitoring high-risk individuals with direct access diagnostics and or active monitoring of symptoms. So you could use as much of the tool as you need to use it across as many ANPs as you like. You just have to make sure that there is a robust checking process at the other end with an administrative function to back that up.
Thank you. Okay, so I'll pick the next question that's come up, which is, so apart from the following up of actions set out within the template, what are the key responsibilities for the administrative staff? And that's a really good question, because as we've all said within our talk so far, is that actually it is such a collaborative process between the admin leading and the clinicians leading. So we've developed a admin facing kind of protocol, really, which we can send you the link for. But in terms of key responsibilities, I would highlight, so identify an admin leadership. So usually, so in our example, in our practice, the practice manager leads on it. Set a date that you want to run that, and make sure that the key person who's responsible for running for checking that search on that day is aware of that, and ensure that when that person is off, that there is a cross cover or second person in line. And the key administrator, essentially, they're not there to do everything, because depending on the size of your practice and how well used the safety netting toolkit is, that determines the number of tracking events that will come up. But they would pull up the spreadsheet, and usually most practices would download that into an Excel, and they would go through all those key events, and there are the simple things versus more complicated things, and the simple things are usually page 1 and 2, which is, did this person attend for their suspected cancer referral, yes or no, and you know, there may be various ways of checking that, whether you check the records, whether you text the patient, whether you phone them up. Those are sort of the various methods that you'd use, and then if it's clear that they have, then the administrator can actually just very easily close that. And what we found is that actually most of our administrators will just put a little entry in the notes to say, yes, patient has attended, or I phoned the patient. And if they've sent an SMS, actually that's quite clearly with Accurix that many of us are using now. That's sort of already saved into the record, so it's clear for anyone who logs into the patient's notes. And then the more complicated things, which usually lie on which page 3 and 4, tend to be sort of more contextual stuff, so things that the GPs have put down about reminding a patient to come and attend an appointment or do a blood test, and those often require the administrator to task the patient, to task the clinician who set that tracking event, or emailing them, depending on what systems that they have in place. And I think the key here is just making sure that whatever actions are done, that they are followed through, and if you have completed it, remember to go to the diary section of that patient's notes and complete that, because obviously what that does is it removes them from the searches, so that every week you're not having that same person pop up on your spreadsheet. Have I missed anything, Rasha or Philippa? No. Philippa's disappeared. Rasha's disappeared. I can't see her anymore.
No, sorry, I'm here.
Your video. Your video's gone.
I just wanted to reiterate very small point that you raised again, that the clinical responsibility resides with the clinician, but you have to have a very good trusted process with your senior administrator. So in our practice, it's our operations manager, our senior receptionist, and our practice manager. All three have been trained to run this toolkit, so that there is never any, you know, it's not missed. The searches shouldn't be missed if there are multiple people. So just have a really robust communication line between the lead clinician and the lead administrator, but clinical responsibility sits with clinicians and administrative responsibility with the administrators.
Thank you. So
yeah,
sorry again, Philippa.
Just going to sort of linked with that really is the closing off the diary entries. So some practices feel that should be a clinician that does that, but then if you've got a very trained team, you might feel that you can hand that over, but when you're actually closing it off, that is kind of taking it out of the workflow system. So you need to be sure that everything that you intended to have happened has happened at that point before you take it out. But you do want to close it because you don't want it to keep coming up on the searches that you run. But yes, who closes it off is an important decision to make in the practice.
Okay, grand. So I've got another question. I'm going to direct it to either of you first. So what problems might clinicians experience in regards to implementation of the matrix? I'd like to take that on. Okay,
so problems. So I think maybe I'll start. I'm sure Philippa has probably had lots of feedback from clinicians, so I'm sure she has more breadth of input for this. But just from our own experience as a clinician, I think this goes back to a common approach in your practice. So I think the challenge always is not to have, exactly like Philippa said, a couple of clinicians who want to use the toolkit and a couple who want to continue on their old safety netting journey. It's really important as a clinician that you get buy-in from your colleagues, because unless you're all doing a common approach, then things are going to fall through the net. So when you're using the toolkit at the desktop, it's really straightforward. It's a matter of a couple of clicks. So I think the physicality of using it is quite straightforward. Your feedback from your administrative team or the next step is quite heavily dependent on what you instruct in that text box. So it takes a minute to think about, actually, if you weren't sitting in your chair and somebody got that information, what you would actually want them to do. We've all got quite good at indication note taking because we all see different patients now, but it's important to translate that into the toolkit is my view.
I think I'd just say that maybe one of the hurdles is actually a bit before that, and actually finding where the template is, finding where the searches is, activating. And I think Vanessa did a one-page summary. We've maybe still got that we can send, which is a step-by-step guide of how to.
Sorry, Philippa, you haven't gone live as yet. Just bear with me while I put you up.
Okay. Am I live now? Okay, am I unmuted now?
I can hear you, Philippa.
I
Okay,
can hear you too, but I don't think.
It's
Oh, you
saying
are
you're
live
not.
now.
okay. I was just saying that I thought that one of the hurdles might be actually earlier on in the the initial setting up, the initial kind of finding the template and activating it, finding the searches and running them. So I was saying that I think Vanessa had done a one-page summary when we were doing the training, and I think that's probably still available, or an updated version. But just to, you know, how to get started might be helpful along with the video.
And sorry, just to echo that, there is a list of resources.
Yeah, I'm
That
unmuted now.
Okay, so can you hear me? There is this final slide shows some of the resources that will become available to everybody, just to follow on from what Philippa said, that there is a piece of work around how to locate the toolkit. There's that great YouTube video, the 7-minute video that really helps you in your training meeting to try and get your team on board. There's a very simple guide for clinicians and this administrative staff user guide. And of course, there's the SOP from which it was innovated from. So quite simple, actual step-by-step documents to get started. We certainly found them useful.
Great. And if I could just add to the clinician's experience, I think what I've found and what I've learned a lot is about how every clinician seems to be on a different timeline. So from implementation or attending a workshop or having had a practice session, some people are certainly more confident in how they use those pages. Everyone seems to be up to speed with page 1 and use that. And then as time progresses, and we're sort of talking about month 2 to month 5 or 6, then you start to, I suppose, clinicians become familiar with how they're getting these tracked events come back to them, and then they start to gain more confidence in how they utilize the rest of it. And I think the one thing I have observed is that, or what I've heard is that through COVID, people are using more of those pages, and we definitely encourage that. There's so much opportunity, and in terms of the ability to be able to code symptoms and code follow-up, that's all embedded into there. So I think that you know, I would say to practices that it would take, you know, sort of between 3 to 6 months before you really start to feel the full impact of how clinicians are using that, and then and obviously resulting from that is the number of tracked events that come up in your searches. Okay, so we've got so Pawan's given us a little thought here. Any thoughts about linking with Accurix and able to send timed text to patients 14 days after referral, so reducing the contact needed by admin staff? That's a really excellent idea.
Yeah.
We haven't thought about that yet. Oh, sorry, go
Sorry,
on.
Afsana, I was just about to say, I'm sure even on a practice level rather than just a toolkit level, if you have an internal process where you empower your administrators to create an AccuRx template that does that, then when they run the search, they can populate that instead of having to call the patient or at any junction, you can empower them to put the template into AccuRx and send it. The only thing you have to then have is a robust system for checking failed AccuRx reports. So just make sure that whatever step you're doing, there is another step behind it. So you have to close that loop somehow and be confident that you've taken all the necessary steps. But I think, yeah, going forward, an AccuRx templated response to the patient would be quite useful. Allowing them to respond once with a text saying they've attended, that would be a really good step.
Grand. Okay, so we've got 5 minutes. I think we can cover the next few questions that have popped up, and we also need to touch on the last slide about evaluation. So perhaps, Vanessa, if I can cue you up on how people can get in touch to get more information on that. But the next question before that is, do you get locums to fill it in if they refer another GP? So I think we get the gist of that. Who'd like to take that on?
We, sorry, I just say we get every clinician that comes into our practice, whether they're a locum, a trainee or a GP, to do it. And what we've done is we've built the steps for this into our GP handbook, and we make sure our locums get the GP handbook on our processes before they join our practices. So we have a GP handbook, we've aligned our locums to follow our internal processes, but when they come in, our practice manager and our operationals manager specifically highlight to them that any 2-week waits need to go through the tracker. It's very useful for that, actually.
That's excellent. Philippa, did you want to add anything?
I think there might be some variation. I mean, it sounds really great, Rasha, that you've got that implemented. I think it might be different in different practices, but as long as you've got a system in place that you know that locums either do this or do that, that yeah, it can be.
Yeah, so we found having a locum pack, just, you know, just one that just defines that process for you, and whether if it's not the locum, then at least the administrators will then pick up any 2-week wait referrals and then read code it. That's certainly been our experience with that. So the next one, before we finish off, I know it might be in the FAQs, can you set recurring alerts into the future for annual surveillance tests, or do you want to have do you have to set a new one after the old one is completed? Who wants to take that on?
I can take that on. Yeah, so that was the fourth page of the template, which is the kind of cancer follow-up thing. So maybe colonoscopy in 1 year. But I think, as Afsana alluded to earlier, you can only set one diary entry. So you can set it for 1 year's time, but you can't set it for 1 year, 2 year, 3 year. You can only set it for one. And when that one's happened, you can set it for the next year.
Yes, exactly. And the key is really about what SNOMED/read code that you're using. So whichever code you're using, you can do, you know, if you want to do something slightly more complex, you can use 2 different read codes to capture the same event if you want to, but within the same read code, you can only do that once. If you do a new one, it will replace the old one. Grand. So I haven't seen any. Oh, sorry, go on.
Sorry, I just want to add a really tiny point to that. That if you write in the free text box, so if you do an annual PSA, so say you do a PSA, you set it for the following year, in your text box, you can write, this patient needs annual PSAs. So please feedback that he has had it and reset for the following year. And then you can check that, you know, it can become a kind of digitized function that you're instructing someone to reset.
That's perfect. So I think that's sort of drawing to the end of the session. So thank you so much. Thank you for the excellent questions. Should we just show, if we just touch on the last slides, and so slide 27, if we can get, yes, so perfect. So it's not showing up for me, but I'm presuming, Catherine, that everyone can see that. Yep. Okay, so this is the slide on evaluation, and we'd really appreciate it if you could spare a few moments to complete that. And then obviously, people have already requested videos, slide decks, information, so we're very happy to send that on. You've got Vanessa's email there, so please make note of that, and we're happy to share that. Otherwise, I think we can draw to a close. Thank you so much to Philippa and Rasha, and obviously Catherine and Vanessa, and we hope you found this valuable. So feedback is very, very welcome.